We are going to start our webinar session. So, everyone, a very good afternoon and very warm welcome to you all. I'm Dr. M. Shah Jaiswal, and on behalf of DBridge, it is my great pleasure to welcome you to today's webinar, that is, Facial Space Infection, Diagnosis, Spread, and Evidence-Based Practice. So, all the dentists and all those who are in dentistry as well as in the medical field, they might be knowing about the facial space infection. It is one of the serious odontogenic as well as non-odontogenic infection that involve the potential spaces between the facial planes of the head and neck. They commonly arise from untreated dental infections, trauma, systemic conditions, and can rapidly spread due to complex anatomy of facial spaces. Early and accurate diagnosis is crucial, relying on clinical examination, imaging techniques, and an understanding of the anatomical pathways of infection spread. If not managed properly, these infections can lead to life-threatening complications such as airway obstruction or intracranial involvement. Therefore, an evidence-based approach integrating current clinical guidelines, antimicrobial therapy, and timely surgical intervention is essential for effective management and improved patient outcomes. So, before we begin, let me briefly introduce you guys to our guest speaker. We are truly honored to have with us today Dr. Saket Jha from India. He did his BDS from KLE Dental College, Bangalore, followed by a junior residency at Tata Cancer Center, Kolkata. He earned his MDS from KBG Dental College, Karnataka, and further pursued a certification in facial plastic surgery from Trustwell, Bangalore. He has received extensive training in aesthetic and reconstructive facial surgery and has made notable contribution to the field, with over 30 publications in peer-reviewed journals. He is the founder of Contour Cosmetic Clinic, Bangalore. His areas of expertise include oncologic reconstruction, prosthetic implants, and advanced cosmetic procedure, where he integrates innovation with evidence-based practice. Uh, Welcome, Dr. Saket, on board. And today's session, this has been carefully curated to provide both scientific insights and real-world clinical challenges. So, in this exclusive webinar, we will talk about, understand about the etiology and the anatomical pathways, and then clinical and radiographic approaches for the early diagnosis, and evidence-based management protocols, which includes antibiotic selection, surgical drainage techniques, and prevention of life-threatening complications. So before we begin, a quick note to all the participants that if you have any questions during the session, please feel free to post them in the chat box, or maybe you can raise your hand at the end of the session. So we will address that questions during Q&A segment at the end of the session, and it will be more of like interactive session where we can discuss all together. So without further delay, let us begin the session. So over to you, Dr. Saket. You may start now.
Hi everyone, myself Dr. Saket. So we'll be discussing about the facial spaces. We'll be discussing about the definition, classification, clinical features, management, complications, few case studies, and how we are dealing in the current scenario. Coming to definition, a facial space infection is basically it generates from odontogenic or non-odontogenic infections. It spreads to the facial spaces which are not tightly packed and spreads. It commonly starts with dental infections, pathogens, spread by facial roots, connective tissues, and can be life-threatening. When it goes towards the superior side on the upper area, it can lead to cavernous sinus thrombosis. When it goes towards the neck, it can lead to Ludwig's angina. So common etiological factors in odontogenic infections are dental caries, periodontal abscess, pericoronitis, post-extraction complications. In non-odontogenic, it can be due to trauma, any existing trauma or laceration wounds, sinusitis, silidinitis, or any skin infection. When we talk about microbiology, there are two different organisms, anaerobic and aerobic. So when we give treatment, we have to target both the organisms. In aerobic, we have streptococcus, different variants of streptococcus and staphylococcus. In anaerobic, we have bacteriocytes and different anaerobic bacteria. A mixed combination of treatment is required when we treat facial space infections. Coming to anatomical concept, how facial infection spreads. It starts from the least resistant space, the space which are very violent and in which we can penetrate easily. It undermines the muscle attachment relation to the tooth apex. connective tissue expansions, and it helps in expanding the connective tissues and leading to spread inside those connective tissues. When we talk about facial space infections, there are different theories of facial spaces. Starting from the first physiology of facial space, how it starts. It starts from basics like dental caries. Initial dental caries penetrate from enamel to dentine, leading to pulp, causing pulp necrosis. Coming down to periapical infection, cortical perforation, spreading to facial spaces and forming abscess cellulitis, or further more dangerous conditions like cerebrospinal or the lower facial space infection, deep facial space infections. In an anatomical pathway, it starts from pulp necrosis. Bacterial invasion in those dental pulp spreads to the cortical bones, perforating your cortical bone, reaching to your facial spaces. Key determinant factors are root apex, thickness of the cortical bone, and the least resistant spaces. When we talk about the spread of infection, there are different factors which are affected in facial spaces. First is the tooth apex position, how deep it is or how superficial the tooth apex is. Muscle attachment, the surrounding muscles, be it buccal space or canine space infection, the surrounding muscles are the first muscles which get invaded during these space infections. Thickness of a cortical bone, more the thick bone, less chances of penetration is there. Organism, in bacterial organism, it can be organic or anaerobic or aerobic bacterial infections, and how strong your immunity is, and how fast it can tackle those infections. When you talk about facial space infection, from the mandibular infection, it follows towards the downward path, that is the neck, infected to submandibular gland, pharyngeal spaces, and mediasternal, leading to Ludwig's angina and blockage of your airway. When we go towards the upward, that is maxillary tooth infection, it leads to canine, orbit, and cavernous sinus thrombosis. So when we classify facial spaces, we divide into different parts. It can be superficial or deep, primary, secondary, or the deepest neck infections. Primary infections are still very easy to treat, and it's not that dangerous as compared to the deep neck infection. When we talk about the primary infections, primary spaces, these can be the open spaces like buccal, canine, sublingual, submental, and submandibular spaces. Secondary spaces are a little deeper than the primary spaces like mesenteric space, temporal, infratemporal, or pterygomandibular space. When we talk about deep space infections, these are most life-threatening spaces and other dangerous area of your face. It can be parapharyngeal space, retropharyngeal space, a space at the backside of your neck or the surrounding anatomy of your neck. In buccal space, there are boundaries which surround the buccal space. It is surrounded by 4 different boundaries: medial, lateral, superior, inferior. Medially, it has buccal buccinator muscle. Superiorly, we'll have skin and superficial fascia. Above that, we'll have zygomatic arch, and the below is mandibular border. This surrounds the facial space. When we penetrate the facial space, buccal space downwards, it leads to sublingual space, which is below your tongue. It has superior boundary of oral mucosa forming by the floor of the mouth, mylohyoid muscles, which is the below part of your sublingual space. Lateral boundary is the mandibular bone, and medial is the genioglossus muscle. When we have sublingual space, your tongue, lower part of your tongue and the back of your tongue will be a little elevated as compared to the normal position. In submandibular space basically involves a submandibular gland. There can be a mylohyoid muscles on the superior sides, deep cervical fascia, laterally bone of the mandible, which is the cortical bone of the mandible, and medially we have digastric muscles. When we talk about canine space infection, canine space infection caused due to the infection when it's in your canine or premolar region. It spreads from levator, levi superioris, orbicularis oris, lateral aspect of the nose, and laterally it's surrounded by the superior facial muscles. So what are the clinical features we see in facial space infection? The most common features locally which we see is swelling. There will be a slight enlargement on your face, asymmetry of the face, facial swelling, localized rise in temperature, pain and tenderness, trismus, limited mouth opening. Your mouth opening reduces to 2 to 3 fingers. Dysphagia, difficulty in swallowing. When you have the lower facial space infection, it leads to dysphagia. Trismus is mostly seen in the lower facial space infection, not in the upper one. And tenderness of the tooth and mobility of the tooth. In systemic, we can see fever, chills, malaise, fatigue, tachycardia, elevation of WBC counts, and dehydration. So when we inspect facial space infection, first we see clinically, then we palpate it. While inspecting, what we see is a mild or major facial asymmetry. It can be unilateral or bilateral, depending on the faces involved. In Ludwig's angina, mostly it's bilateral. Overlying erythema, skin changes, raise in temperature, that trismus, reduced mouth opening to two finger, elevated floor of the mouth. When we palpate, we can see the increase in temperature, localized tenderness, induration surrounding the tissues, fluid accumulation, and crepitus. Most of the time, when we press these swelling, these are not fixed. It's a mobile swelling. It moves from one space to different spaces and has edema. So when we go with the investigations, we start with clinical examination followed by radiological investigations. In radiology, first we go with the OPG or IOPR, which is the basic one. We'll start with IOPR. We'll see the adjusted tooth nearby the swelling, which all tooths are involved. We'll be going and doing the IOPR. We'll see how the tooth structure is the pulp involved, periapical abscess is there or not. Followed by OPG, surrounding space, if they have, is the space having tumor, cyst, or it's only the facial space. We can go with ultrasounded, FNAC, CT, and MRI. CT and MRI we go on the later stage. First, we start with OPG IOPR. What we see in OPG is a periapical radiolucent lesion around the tooth surface. In USG, when we do USG guided FNAC, we do a needle aspiration. We find fluids from the facial spaces, which helps in determining the type of facial space infection, and that same fluid will be sending for culture and sensitivity to know if the particular patient is resistant to which of these antibiotics which we are advising him. Accordingly, we'll prescribe the needed antibiotic. Again, coming to MRI or CT, MRI helps in knowing the soft tissue structures surrounding the facial space infection. This is the standard protocol for deep facial space infection. When we talk about CT helps us in seeing the cellulitis pattern, diffuse soft tissue density, abscess formation, gas pockets, and multiple space involvements. If you have a upper face, temporal, buccal, canine, multiple space infection, multiple swellings, you can go with CT. It helps in seeing the bone structures and the surrounding pockets. In early recognition, swelling pattern can be seen. Anatomical landmarks can be help. Particular guiding of the anatomical landmarks help us to know whether the facial space infection is in buccal or canine or a particular space. Having a certain anatomical knowledge helps us in knowing the spread of infection and stopping it at a particular time. Imaging helps us in guiding with the treatment protocol, be it radiograph, MRI, or CT. And then comes the treatment plan, which is aggressive management. It can be medical or surgical depending on the type of infection and the spread of infection. So coming to differential diagnosis, when the investigations are done, when we had seen the swelling clinically, investigations are done, we come to a final conclusion, whether it's a cyst, abscess, cellulitis, osteomyelitis, or facial space infection. So how we differentiate between all these things? Coming to cellulitis, cellulitis is a diffused erythema without pus collection. In cellulitis, you won't have pus. If you have pus, it turns into abscess, not cellulitis. Tumor is a slow growing mass. It won't have any fluid accumulated in it. Again, when it comes to cyst has different fluids. Every fluid has their own component, which leads to differentiate between types of cyst. It can be dentagenous cyst or any different types of cyst. Then comes salidinitis. These are mostly associated with the salivary gland disorders. If you have any duct or stone in duct occuma, when your duct is blocked or you have stone in your salivary gland, it leads to salidinitis and silo. Then comes the lymphadenitis. In this, lymph nodes are tendered and these are enlarged. It can be seen in tuberculosis or SCCs. So these are different factors which helps us in differentiating between facial space infection with other types of infections. Coming to golden principles of treatment in facial space infection, we basically follow ABC protocol. First is the airway management. We have to rescue the airway. We have to see if their tongue obstruction is there or not. Tongue is blocking your airway. First, we have to do airway, clearing the airway. If you have any obstructions orally, we have to go with intubation or tracheostomy. Then removing the source of infection, whether it's the infected tooth or any trauma, any foreign body which leads to in these infections, we have to remove those. Then comes the surgical management, which is draining out the pus. incision and drainage, which we basically do with Hilton's method, and followed by with antibiotic support, broad spectrum antibiotic targeting both aerobic and non-aerobic bacteria. Once the patient is treated and 2 or 3 days protocol has been followed, we start with the supportive therapy of IV fluids and nutritional support for reducing further complications. When we talk about medical management, we have different lines of treatment in medical management. The basic treatment which we start with is a double dose of antibiotics, which is amoxiclav and metronidazole. Amoxiclav and metronidazole helps in acting, a combination of antibiotic helps in acting on both aerobic and non-aerobic bacteria. So we can target both the bacteria with these antibiotic combination. This is one of the first line of treatment which we give in space infection. Again, we give a double dose. Normally, what we give is 1.2 grams of amoxiclav. In facial space infection, we give a double dose of it for the initial, for the first time, and followed by the same single dose for next 2 to 3 days. Again, we go with the IV therapy instead of oral because the spread of infection is very fast. To control it, we have to go with IV. If patient is allergic to any of these antibiotics or the antibiotics is not responding, we can go to clindamycin or we have to do culture and sensitivity. With that, we'll see patient. We have to see whether which all the antibiotics patient is resistant to. We have to change it and advise a particular antibiotic. Coming to surgical protocol, how surgery before, what we used to do is first we start like 2 to 3 years back, what we used to do when we see a facial space infection patient, first we admit it, we start with antibiotics, then we go for surgical management. Now we have changed the protocol. First, whenever we notice the patient has facial space infection, we diagnose it. We start with the surgical management, that is incision and drainage, followed by antibiotics. We don't give that time period or the space for the infection to grow forward. So indication of surgery is when the confirmation of abscess is done by imaging. Airway is compromised. In that case, we have to do immediately IND. Failure of antibiotic in 48 hours. Any tooth extraction of the particular source. In modern protocol, what we do is we do a CT to get an accurate diagnosis. USG guided FNAC, sending sample for culture and sensitivity. Starting with the antibiotic based on the sensitivity testing, same what I've told, culture and sensitivity. Early drainage and before the airway got compromised, and multidisciplinary approach involving early ENT and office surgeons. Surgical, when we do surgical intervention is when the abscess is formed, when there is a fluent pus discharge or the fixed pus into the facial space, which is not draining out. First, we mark the complete area where the infection is, making the lowest point of the swelling towards the gravity. We mark a nick using a BP blade or any incision. A blunt incision is made on the particular swelling part, breaking and separating the loculated pocket and completing the pus evacuation, irrigating it completely, saline betadine, removing the debris surrounding tissues, space for the draining out of the remaining pus and controlling the source of infection. When we talk about Hilton's method, this is one of the most asked questions during our viva or in our examination. So Hilton's method is one of the good or great method doing incision and drainage, in which we go with the blunt object without harming any of your major vessels or vital structures. How we do incision and drainage in Hilton method is, it was invented by John Hilton in 1804. In this, we make a blunt incision on the skin. We use a forceps, making a precise incision on the point of entry with a closed forceps which does not have a pointed nip, will penetrate it inside without damaging any of the vital structures, any artery, veins, or the critical anatomical structure. With the closed artery forceps, we go close to the dip of the highest point where the infection is. Then we open the forceps slowly and we'll try to penetrate in different facial spaces, expanding those spaces, creating space between those spaces, allowing the abscess to drain out from the cavity, enlarging the tract. While forceps, when we open these forceps, it helps in protecting the surrounding area, also creating a channel in which the abscess will come out. This allows us to drain out the material from the abscess. Once the abscess start draining out, we'll apply pressure from outside, try to push out the remaining abscess from the remaining fluid from the surrounding tissues, and we'll put a drain, tying it with corrugated drain or with the suture for the next 2 or 3 days. Advantage of this Hilton's method is it prevents vascular injury. No vessels or major vessels artery is damaged because the forces which we use is blunt. It protects nerves, control the entry. We know how deep we have to go, how to control and how deep we have to go, when to expand, when we have to close the forceps. Mostly we use is the mosquito forceps. And then comes the tissue prevention, might minimize trauma to the surrounding tissue. Coming to case-based management in different facial spaces. When we talk about submandibular space, which is the lower part of your face, lower jaw, and the right side, which is involved by the premolar, molar, or which originates from the mandibular molar, patient present with swelling, pain, trismus on the lower part of your face. Most of the swelling is near the second molar to the premolar area. Management is again incision and drainage with IV antibiotics. When it comes to temporal space infection, which is the upper part of your face, first we'll extract the tooth, which is the source of infection, be it the molars or the premolars of the maxillary region. CT is done for the to see the involvement of this temporal extension, how far it is going into your temporal spaces. Surgical intervention is done again incision and draining, making sure that you're not penetrating to any of these deep structures or damaging any of the artery or veins of the face. Coming to danger pathway, there are different spaces on a face which is known as danger area of the face. This can be between the ala and prevertebral fascia, extending from the skull base to the mediastinum. It can be parapharyngeal spaces which communicate between the deep neck spaces, which helps in extensive spread because the tightness between the space is very less. So it can expand deeply and very extensively. Then comes canine space infection. This canine space infection starts from facial vein. It goes to your dangerous area of the face, which we call the middle, below the nose, on the surrounding of the auricularis. So, this orbital and this ocularis solis muscles. This starts from it has a communication of facial vein, angular vein, ophthalmic vein. If this space involves, it can directly lead to cavernous sinus thrombosis. Coming to critical symptoms which are associated with facial space infections. These can be it can be Ludwig's angina, cavernous sinus thrombosis, necrotizing mediastinum, which is very deep. Well, it's not involving the mediastinum. It can cause Lemur syndrome. In this, the difference between necrotizing mediastinitis and Lemur syndrome is IJV. IJV is involved in Lemur syndrome. In necrotizing mediastinitis, that is not involved. That is the only difference in both the syndromes. Coming to Ludwig's angina, one of the most common angina, most common swelling or the complication which we see in facial space infection if it's not treated on the right time is Ludwig's angina. It involves the bilateral submandibular or sublingual spaces, which is mostly the lower part or the lower jaw of your face. Swelling characterized by the woody hard swelling. When we touch it, it's very hard in palpation, indurated, rapid progression, and minimal fluctuated. Tongue will be elevated in Ludwig's angina, posterior elevation and airway obstruction will be there, causing dysphagia. So, early signs of Ludwig's angina, it can be bilateral submandibular swelling, elevation of tongue, inability to swallow because of drooling and obstruction, and stridor changing voice. Coming to Lemur syndrome, it causes because of the fusobacterium. It is anaerobic gram-negative bacteria. There is septic thrombophlebitis in the IJV, leading to clot formation. It spreads to your lungs, leading again. It forms a septic emboli, travels towards your lungs, causing pulmonary infiltration. Clinical signs can be neck pain, severe fever, sepsis, chest pain, or respiratory distress. When your facial space involves the canine, orbital, or the upper facial spaces, it can lead to cavernous sinus thrombosis. The origin is from the canine spaces or the facial danger triangles or the upper facial spaces. It affects the eye sign, leading to proptosis, bulging of eye, ophthalmoplegia, which leads to paralysis of facial space orbital muscles, or ptosis, drooling of eyelid. There will be high fever, spike, chills, and systemic sepsis. There are again different parameters in which we measure cavernous sinus thrombosis, known as Eggleston criteria. Eggleston criteria is a criteria having 7 factors. When these all 7 factors meets, it can lead, or we can differentiate into a cavernous sinus thrombosis. It is a aggressive treatment management protocol which we follow for cavernous sinus thrombosis. What we see in this criteria, Eggleston criteria, is there should be a very high spike of fever, which is more than 38 degrees Celsius. Tachycardia should be there. Airway should be compromised, that is dysphagia, stridor, drooling, or flow of the mouth elevation. Rapid spreading infection. It spreads from one space infection to other space infection, leading to cellulitis and fluctuate developing. Trismus, mouth opening should be reduced to 20 to 25 mm, that is 2 fingers, which required immediate intervention. Deep facial space involvement, like submandibular, maxillary, or the canine space infection. Patient should be immunocompromised. Most of the space infections are seen in the patient who are diabetic, which because due diabetes they are immunocompromised, which creates a high tendency of these infections. So immunocompromised patients like diabetic mellitus, steroid therapy, HIV, or immunocompromised patient. Again, if not proper treatment is given in next 24 to 48 hours, patient has chances to create a life-threatening condition. So how to treat cavernous sinus thrombosis? So first protocol is to immediately admission of the patient, clearing the airway. If there is blockage of the airway, we have to do intubation or tracheostomy, starting with IV therapy, both high dose broad spectrum antibiotic and aerobic and anaerobic. Monitoring the airway, seeing the respiratory compromise, if respiratory is compromised or not. Early surgical drainage, again incision drainage, followed by IV therapy. So for the knowing mnemonics for this Eggleston criteria is FAT trips, which is fever, airway, trismus. Treatment failure, rapid spread, immunocompromised, poor swelling, and space involvement, which is the different spaces involved. Coming to descending necrotizing mediastinitis. These involves the lower part of your face, which is below the jawline, involving both of the neck and the mediasternal area. It spreads from neck to the mediasternal by dangerous spaces, which is the open pharyngeal parapharyngeal spaces. It perforates the facial plane. It leads to chest pain, dysphagia. Again, there is a sign in which we see in necrotizing mediastinitis. This is known as Hammer's signs, which is crunch in the mediastinal area and high fever. When we do CT, we see a gas pouch or the gas fluid involvement in the mediastinal area, forming a cavity into those areas. There is a high chance of mortality in these cases without immediate intervention. So when it comes to Ludwig's angina, lower facial space, deep facial space infections, so cavernous sinus thrombosis, an immediate protocol should be followed and immediate surgical intervention should be done to protect any life-threatening disorders. How we differentiate different types of syndromes clinically and with investigations. When it comes to Ludwig's angina, there will be a bilateral swelling on the both sides of submandibular sublingual area involvement. When we have facial space, it involves only either one side, that is the lower part or the upper part of the face. When we have Ludwig's, it involves bilaterally. When it's Lemur syndrome, there is an emboli in the IJV and thrombophlebitis leading to pain. You'll have a severe chest pain in these conditions. When it's cavernous sinus thrombosis, the main sign which we see is the eye. There will be edema and erythema in and around the eye. Chemosis will be there, ptosis will be there, and a severe headache. Patient will have a severe headache leading to high fever and a few other conditions which are involved with the cavernous sinus thrombosis. When it's necrotizing mediastinitis, there will be a thoracic sepsis spreading by the dangerous spaces to the mediastinal area, and a gas pouch will be seen in the mediastinal area. So key points when we treat all these facial spaces. First is incision must be dependent. When we do incision, we have to do it at the lowest point where the gravity is high of the facial space to prevent the recumulation of these abscess or pus again into those spaces so that it drains out directly out from these facial spaces. Never rely on antibiotic alone. So we should never rely on only the antibiotic therapy. We have to do surgical intervention with the antibiotics. Airway first protocol. Again, we have started with ABC. First, we have to clear the airway, be it tracheostomy or intubation, to prevent further respiratory distress. We have to break all the loculations. When we treat facial space, we have to go inside, clear all the facial spaces, creating the cavity, clearing it out. Consultation. 10 minutes. Yeah. Always remove the infection sources. So, be it dental infections, any trauma, any foreign body, we have to remove it during the time of treatment. When we have started with the surgical intervention, first thing is first we have to remove the source of trauma, source of infection, which is the tooth. Once the extraction is done, then we have to start with the incision. So, a consent criteria guides admission decision. So, when the patient is meeting with all the 7 criteria, the first thing we have to do is to admit the patient, start with IV antibiotics. Early knowing about these symptoms helps in saving lives. We have to monitor airway systemic toxicity, rapid progression of the disease. Then once the IV starts, same time you have to start with surgical drainage, be it IND or a small nick, putting a drain, leaving it up. If not treated on the right time, it can lead to further complications like Ludwig's or Kevin sinus. Coming to evidence-based protocol, what we are following from 23 to currently, modern management of these space infections are determined on the clinical examination, image-guided intervention, and antibiotic protocols. Early severity management should be done. Airway first approach should be done. CT, in most of the cases, now we are going for CT instead of IOPR or OPG as the first protocol to reduce the time duration and give a immediate treatment. Early surgical drainage, controlling the source of infection, and antibiotic therapy. In high risk indicator, there are few things which are elevated and compromised. That is, dysphagia and dyspnea will be there, which leads to respiratory distress. Multiple organ involvement will be there. Immunocompromised patient will be there. Elevated CRP will be seen in the blood reports. When we talk about airway first approach, either we can do fiber optic intubation, which is image guided intubation, which helps in going to the particular anatomical structure very easily without, as compared to the blind intubation. Second comes the tracheostomy. If you are not able to do intubation, the best option we do is tracheostomy. Either we can do open or closed tracheostomy to prevent collapse of airway. Most of the time, now what we are doing is we are doing image guided intubation instead of doing blind intubation, which we used to do before. Early enhanced contrast CT is a gold standard protocol for investigation in facial spaces. It helps us in clinical, it gives a clinical benefit by differentiating cellulitis with abscess, define facial spaces, guide surgical incisions, detect mediastinal spread and complications. So with the CT, we can easily see the spaces which is involved, which we can't see clinically. So what has been changed in past few years in the treatment protocol, be it surgical drainage or the antibiotic therapy? In old concept versus new concept. Old concept, what we used to do is we used to give antibiotics before and we delayed the surgery. Once we see in 2 days that swelling is reduced, we most of the cases we don't go for incision and drainage. We'll subside the swelling with antibiotics and we leave it there. In the recent protocol, what we are doing is once the patient comes to our OPD or casualty, we start with a double dose of antibiotic, and in next 2 hours we go with incision and drainage followed by antibiotic to reduce the complications. Also, the reducing the time. So first we do is a radiological examination with CT MRI. Blood test, systemic blood test should be done to mark all the toxicities and inflammatory factors. Multidisciplinary space infections should be managed with same incision and drainage in the facial compartments, and a lack of improvement with medical therapies. If we are not doing all this thing, it can lead to in next 24 to 48 hours, it can lead to a severe fatal infection. Coming to multidisciplinary management, there are different specialities which operates on head and neck. It can be plastics, ENTs, general surgeons, or maxillofacial surgeons. A combined approach of all these specialities can help in diagnosing and treating facial space infection in a particular better way. When we talk about the neck or deep pharyngeal, parapharyngeal spaces, ENT surgeons are more expert or more trained in handling the neck spaces as compared to maxillofacial surgeons. When we do upper space or the facial space infections, we have a thorough anatomical clearance or the guiding, or we know better anatomy when we talk about the facial spaces. So combination approach of these specialities can help in diagnosis, treatment, and stopping the spread of these infections. Coming to USG guided protocols, when we talk about the USG, a recent what have been changed as compared to the past. When we start with USG guided FNAC, there is a pandemic shift in managing these infections. When we talk about USG in the real time scenario, the USG guided FNAC helps in minimizing invasive alternatives to traditional surgical approach. When we do surgery without USG guiding, there are chances of damaging the vital structures, or we are penetrating deep or superficial to the structure. We are not going to the appropriate plane. When we do with USG guided, there is a minimal invasive drainage of superficial spaces, bedside procedure without operating room requirement. So USG guiding FNAC or USG guiding drainage can be done on the OPD itself. You don't have to admit the patient for the treatment or the protocols. The monitoring protocol, we have to see for continuous pulse oximeter. We have to see patient pulse, CPR levels, rising level of CPR. After 2 or 3 days, we have to see his culture sensitivity test. We have to do CBC, a complete blood count, repeat imaging if patient is not getting treated. So management algorithm in according to 2025 to 2026 guideline. How we start space infection, how we start treating space infection is first immediately evaluation of the compromised airway space, be it intubation, tracheostomy, or tongue elevation. We have to pull it out. Elevate severity. We have to make different protocols or different stagings in which we separate different types of spatial space infection. Clinical assessment should be done, removing of severe toxicity and anatomical extensions till how extent that space infection has gone. CT being a gold standard protocol in today's investigations, starting with IV antibiotic, combining aerobic and anaerobic antibiotics to give a broad spectrum coverage. Early surgical incision and drainage, removing the source of infection. Culture direct therapy. Once the patient you have to do culture and sensitivity, get the antibiotic, particular antibiotic which is resistant, we have to remove that, which is sensitive, we have to start on the particular antibiotic, and close monitoring of the patients. Thank you.
Thank you, Dr. Saket, for such a wonderful presentation. So now you guys can put your questions in Q&A box. Meanwhile, I will be talking about D-Bridge, and later we can discuss about the questions. Okay. So yeah, let me share my screen. So basically, this D-Bridge is an integrated platform which is totally dedicated to bridge global expertise with local clinical practice. So we are basically a Korean-based medical and dental platform that connects education, community, and clinically proven technology. So basically, what we do is that we provide evidence-based education and webinar, doctor-to-doctor clinical exchange, curated medical and dental solution for daily practice, and evidence-based information regarding Korean skincare and facial aesthetics. What is our vision? So our vision is to democratize access to high quality medical education and technology so every doctor can deliver safer and more predictable care to their patients. Our guiding philosophy is learn, apply, and share. And this is our website, and we are proud to offer unique opportunities to our clinical partners. Active engagement with D-Bridge unlocks exclusive benefits such as sponsorship opportunities, KOL collaborations, access to international speakers, and then also invitation as a guest speaker at webinars or conferences, special course discounts, but it is subject to applicable terms and conditions. So this is our website. You can access our educational courses and our online mall featuring curated dental and aesthetic products. And we are also across all the social media platforms where we are regularly sharing educational content, updates, and upcoming events. These are some of our key highlights, and we take pride to tell that we have participated in AOMSI and EPEC 2025, and we are ready to make more memories. And yes, we also, as I told, that we also gives courses also related to facial aesthetics as well as dental. So if you want to have any courses, DM us and the whole courses will be curated for you. This is our team. It is a small but impactful in vision. And here are some of our global partners. And for any queries, you can contact us via WhatsApp or via email. And yes, feedback is very mandatory, like very important for us because it will help us to improve and prepare for the next webinar session. So everyone kindly scan this QR code, and later we will also send this feedback survey via email to all the registered participants. Yeah, thank you. And now we can discuss the questions and answers. So there are a few questions that I got via Google form. So let me take that questions first. So yeah, first question is diagnosis and treatment of descending necrotizing mediastinitis. Dr. Saket, I think you have already covered. So if you want to cover in a very brief note, you can tell that what are the diagnosis and treatment of descending necrotizing mediastinitis.
So when we talk about necrotizing mediastinitis, the most common thing which we see is the swelling on your neck, swelling on the neck area, fluctuant swelling. There will be dysphagia, difficulty in breathing, elevation of tongue, and involvement of a facial airway compromise, and difficulty in breathing. First thing is what we have to do, as I have said, is airway obstruction. We have to remove the obstruction of the airway, starting with intubation or tracheostomy, maintaining the pathway to breathe. Once the patient is stable, we have to start with IV antibiotics followed by incision and drainage, removing the source of infection, be it dental caries or the trauma or the foreign body that we have to remove, followed by putting a drain in a particular area.
Mm-hmm. Okay. And the next question is how to take care of vital structures while using sinus forceps.
When we are using sinus forceps, we have to be very cautious. We have to know that which forceps we are using. Most of the time, we go with the mosquito forceps. We have to go when we are going through these facial spaces. We have to go with the blunt incision using a blunt forceps so that you don't hit or damage any of the artery, vein, or the vital structures. Once you reach to a particular space, you have to palpate it from the clinically from the skin layer. You have to see whether your forceps is. Once you are confident that your forceps is a particular anatomical location, you have to open and spread it. You don't have to enter with an open forceps so that you don't damage the surrounding tissues.
Yeah. Next one is first line treatment for facial space infection.
As per current protocol, what we do is once we get the patients, when we see the patient, first we start with the double dose of antibiotic. On the same time, we'll be doing with incision and drainage. We won't be delaying the treatment, surgical treatment. For the first 2 hours, we'll be giving a high dose of antibiotic, double dose, followed by incision and drainage. Then we'll be continuing with the IV dose for next 2 days, 2 to 3 days, depending on the condition.
It is about the importance of gemin. I think he is talking about Gemini quaternary silence. I think I have read somewhere about it that it is, basically it is not a major treatment plan for the facial space infection, but it is basically you can take it as a primary adjunctive treatment for using this because it is a kind of compound, which targets the wide range of microbial spectrum. So yeah, you can use it. However, you cannot just leave the surgical approach. You cannot replace the surgical drainage or the antibiotic therapy with this one. So I hope you might have got your answer. Next one is want to understand the facial protocol. I think he has already cleared about it. Next one is Lemire syndrome and its management. So could you please briefly tell us about this Lemire syndrome and its management?
Lemire syndrome is again when there is a thrombophlebitis around the IgV. It's lead to blockage of your interjugular vein. Again, it involves your deep neck space instead of facial spaces. When your lower facial space infection spreads toward the face, neck area, it leads to blocking of your IgV and carotid both.
Yeah.
So to control these infections, first we have to first protocol is remove the source of infection, start with IV antibiotics, incision and drain. Again, if any of these major artery and vessels are involved, First, we have to start with blood thinners, reducing the clot factors. And if your IGV is pressed, we have to open it surgically, removing the abscess and pus, making a small nick on the particular area, which is the lowest area of your swelling, and try to drain out the pus. Even after that, you are seeing the patient is having difficulty. Also, your airway management, you have to go with tracheostomy or intubation.
Hmm. Yeah, and I think I would like to add that in this case, I think the gold standard to find out this one is CECT, that is contrast enhanced computer tomography. So you need to go for this, and obviously the blood test, because Dr. Socket already told that we need to find out the CPR levels, and there is a condition of elevation of the leukocytosis will be there, or there can also be this ESR elevation. So yeah, you have to check it out. So another question we will take from the chat box. So first question is from Nishan P. Hello doctor, I'm Nishan, BDS graduate from Bangalore. My doubt is, as per revised protocol, instead of prophylactic antibiotics, we direct go with incision and drainage. Does the same apply for retropharyngeal space infection? And retropharyngeal space infection surgical management is taken care by OMFS or ENT surgeon.
Okay, so when we talk about retropharyngeal spaces, again, these are deep neck space infections. So even in these infections, source of infections and abscess is same. So yes, surgical protocol will be a first line of treatment as compared to antibiotic, because airway is compromised. We have to do intubation or tracheostomy, followed by incision and drainage to protect any further complications or the spread of infection to the deeper area. So surgical intervention is the first line of treatment, be it neck or the facial spaces. Again, coming to ENT or OMFS, it's about the clearance of anatomy. If OMFS is trained enough and he's trained in the anatomical anatomy of the neck, as we deal with submandibular glands, sublingual glands, and the neck dissection. When we talk about oral cancers, head and neck cancers, we do neck dissection. We know the planes from level 1 to level 5 lymph nodes we did dissect. In most of the cases now, what we are doing in oral cancer, we are doing thyroid, we are doing pharynx, we are doing larynx. So we are thorough with the anatomy. So be it ENT or OMFS, until you are thorough with your anatomy, you are not be able to treat any of the neck infections. So it's not about the speciality, it's about the clarity of the anatomy. If you are clear with the anatomy, being an OMFS, you are allowed to treat neck.
Yeah. And if you are confused and if you have any doubts, you can just go for the multidisciplinary approach.
Yes.
Yeah. And there is another question from Anshuman. Good afternoon, seniors. I'm practicing in a tier 2 city and I deal with these cases. So my question is, can the first line of treatment be incision and drainage?
Yeah, so IND we can do. Again with that. We have to start with that same time. If you're doing OPD or this daycare protocol, you can start with IV antibiotic or double dose at the same time. IND you can do on the same day.
Yeah.
You can send back the patient. If the swelling is not severe, you can send back the patient. You can call morning, evening for the IV dose.
Yes. And there is another question from Anshuman. Does extraoral incision and drainage is safer than intraoral?
Extraoral. Depending on the area of swelling, where the swelling is. If you have submandibular, sublingual swelling, we mostly go for extraoral incision than going to intraoral incision. Again, if the swelling is, you have a very large swelling having the lowest part on the angle of the mandible, will be going with extraoral incision instead of intraoral incision. Intraoral, we only remove the source of infection, that is the tooth, and the extraction socket, we try to remove the pus as much possible. Most of the cases we go with extraoral incision.
Yeah. Next question is from Nishan P. How do we diagnose retropharyngeal space infection clinically?
Uh, yeah.
Yeah,
Clinically,
he already discussed about it. Yeah, but yeah, if you want to add something, yeah, doctor.
when we talk about clinically, again, we can't clinically differentiate between spaces when it comes to neck, because neck has most of the structure of neck is under the layers. So we can't see whether it's retropharyngeal, parapharyngeal space infections. You'll see swelling, which helps you in diagnosing whether it's a facial space infection or a tumor or something. Once you differentiate between the facial space infection, then you have to go with the same protocol. Once the CT is done, with CT you can know the particular space. Clinically, you won't be able to differentiate between retropharyngeal, parapharyngeal, or Ludwig's.
Okay, I think this was the last question. So thank you everyone for joining with us. And like some of the key takeaways can be like early diagnosis is critical and we should understand the anatomical pathways and can plan treatment accordingly. Okay. And the most common, I think, the origin for this infection can be the odontogenic origin and rapid spread can be the life threatening. So if it is extending below the like deep neck spaces causing airway compromise or intracranial complications, so it can be life threatening. Airway management is a priority. Like so many times Dr. Saket also emphasized that ABC we should just follow this protocol. Then evidence based antibiotic therapy, you need to like based on the culture sensitivity and everything, you need to check it out and accordingly you have to plan your antibiotics. Then timely surgical intervention, incision and drainage is the gold standard for facial space infections. And then patient specific care, like for instance, if anyone is having immunocompromised patient or if anyone is having systemic conditions like diabetes mellitus, so this may influence disease progression and the treatment response, so we have to treat them accordingly. And at last but not the least, prevention is the key. So maintaining the good oral hygiene and early treatment of dental infections significantly reduces the risk of this. So, thank you all for joining with us today, and we are truly overwhelmed with your enthusiastic participation. And we will be sharing our feedback survey shortly via email, and kindly just fill it. And yes, on behalf of Daybridge, I extend our heartfelt gratitude to our esteemed speaker, Dr. Saket, and of course, our Daybridge CEO, Ms. Leena An, and of course, at last but not the least, to all our valued participants. We look forward to welcoming you again at our next webinar session. Until then, keep spreading knowledge and continue to embody our motto, that is learn, apply, and share. Thank you and have a wonderful evening, everyone. Thank you, everyone, for joining with us. Thank you, Dr. Sakit, once again, and Miss Leena. Thank you once again.